The room had already gone silent. Monitors flatlined, wires disconnected, and nurses stood frozen in that solemn moment when life is officially pronounced gone. The fluorescent lights above flickered faintly, casting a sterile glow over his still body. I remember clutching my chest, staring at the sheet being drawn over his face. We had lost him. At least, that's what we all believed. Dr. Mitchell looked at the clock and declared the time of death, 5:47 p.m. His voice was steady, but his eyes revealed the weight of that decision. Behind him, the patient's wife, Maria, crumbled into a chair, letting out a single, strangled sob, the kind of sound that changes a person. I stood by helplessly, feeling that familiar ache of defeat rising in my throat. A nurse gently placed her hand on Maria's shoulder, and someone dimmed the lights out of courtesy. That's when I saw it. So subtle I thought my grief-stricken mind had imagined it. The left eyelid twitched. Once. Then again, slower this time. It wasn't random. It wasn't a spasm. I stepped closer. Did anyone else see that? I whispered. Silence. All eyes turned to the body again. A third twitch, unmistakable now, followed by a faint flutter. And then, his eye opened. Gasps erupted around the room. Dr. Mitchell lunged back toward the bedside. "Get the monitors back," he shouted. In less than 10 seconds, the entire room flipped from mourning to chaos. Code Blue was called again. But this wasn't a code to revive. It was a code to explain the unexplainable. A man who had flatlined, who had no pulse, who had been declared legally dead, and was now blinking at us. You've likely heard of near-death experiences, stories of people seeing tunnels of light or hearing voices beyond. But what happened in room 214 went far beyond the expected. It shattered medical assumptions and brought every doctor in the hospital to their knees. This wasn't a case of someone revived after minutes of CPR. There was no heartbeat, no electrical activity in the brain, nothing. And yet, the patient returned, not days later, but minutes after being declared clinically dead. My name is Dr. Alex Green, an internist with 12 years of hospital experience. I've seen cancer remission miracles, stroke recoveries that defy textbooks, and patients waking up hours after being sedated into a coma. But nothing, absolutely nothing, compares to what I witnessed the afternoon we lost, and then somehow didn't lose, Paul Whitaker, a 57-year-old man who came in for a routine cardiac consult and ended up rewriting everything we thought we knew about consciousness and death. The story isn't just about medical anomalies. It's about grief interrupted, about the haunting tension between science and faith, and about the human body's ability to defy logic when it wants to live. We'll walk through what happened before, during, and after those surreal 7 minutes, from the first symptoms Paul ignored to the final scan that would leave neurologists speechless. Buckle in. This isn't just a story of survival. It's a story that left scars on every person who witnessed it, and transformed how we understand the boundary between life and death. Don't forget to subscribe. Hit that like button and comment below telling us what country and city you're watching from. Paul Whitaker was not the kind of man who went to doctors. If it ain't broken, don't fix it, he'd say with a crooked smile and a stubborn shrug. At 57, he ran his own carpentry business in suburban Indiana, climbed ladders daily, and still carried lumber like a man half his age. But over the past 2 weeks, something had shifted. He started waking up drenched in sweat, his chest tight in the early hours, and a strange tingling creeping down his left arm that he chalked up to sleeping wrong. It was Maria, his wife of 31 years, who pushed him to see someone. "Paul, it's not nothing. Your skin turns gray when you breathe hard. That's not sleep. That's your heart screaming," she pleaded, holding his hand tightly one night as he rubbed his sternum. Reluctantly, Paul agreed to book a checkup with the local clinic. He didn't know it yet, but this small act of compromise would ultimately save, and nearly cost, him his life. During the consult, I immediately noticed his pale complexion, slight tremor in the hands, and his slowed, deliberate way of speaking. A subtle sign I had learned to spot over the years. His EKG showed minor arrhythmias, and his troponin levels were elevated, though not alarmingly so. We decided to admit him overnight for observation. He resisted, of course, saying he had too many jobs to finish, but Maria's glare won the argument. By the following morning, things took an unexpected turn. Paul awoke feeling dizzy and complained of a fluttering in his chest, like a moth trapped under his ribs. His blood pressure dropped to 88/60, and his heart rate danced erratically on the monitor. I ordered an urgent echocardiogram, and that's when we saw it, left ventricular hypokinesis. His heart wasn't pumping with full strength. Something deeper was unfolding beneath the surface. We ran more tests. BNP levels were borderline for congestive heart failure, no signs of clots or valve malfunction. But his cardiac MRI hinted at something more unusual: faint, patchy inflammation, inconsistent with typical ischemic damage. The radiologist called it atypical myocarditis-like features, but no infection markers were present. No fever, no cough, no elevated CRP. It was like his heart was giving out without a cause. As the day progressed, Paul became lethargic, his voice slowing, his words slurring. I walked into his room just after 4 p.m. and found Maria feeding him water with a spoon. He looked up at me and muttered, "Doc, you ever seen someone forget how to breathe?" It sent a chill down my spine. That phrase wasn't medical, it was primal. I checked his oxygen saturation, 92%, dropping. I called the ICU for a transfer. In the ICU, we placed him on high-flow oxygen and started telemetry monitoring. His vitals were unstable, but not crashing. No evidence of sepsis, no stroke. We ran autoimmune panels, viral panels, even tox screens, all clean. Paul was now semi-responsive, blinking but not speaking, staring at the ceiling as if watching something I couldn't see. The attending neurologist, Dr. Simmons, suggested a possible neurocardiogenic mechanism, an unexplained communication breakdown between the heart and brainstem. It was a theory often tossed around in academic journals, rarely seen in practice. "We might be dealing with something akin to Lazarus syndrome," he said quietly, half joking. But none of us were laughing. Maria never left his side. She sat next to him that night, whispering prayers into his ear, recounting memories from their teenage years and begging for one more Sunday morning coffee together. Paul didn't move, didn't flinch, didn't even sigh, but I noticed his fingers curl faintly when she touched his wrist, a tiny defiance of finality. At 5:42 p.m., his heart monitor went flat. The room turned cold. We performed full resuscitation for 10 minutes. Nothing. We stopped. Dr. Mitchell called it time of death, 5:47. But what happened next, just 2 minutes later, would turn this routine tragedy into something no textbook could prepare us for. "His eye just moved," I shouted louder than I intended. The air snapped back into motion. Maria gasped and stumbled backward, knocking over the IV stand. Dr. Mitchell froze, halfway to removing his gloves. One of the nurses, Jenny, looked at me in disbelief. "Are you sure?" she whispered. I leaned in closer. Paul's left eye fluttered open once more. Slow, deliberate, as if trying to pierce through layers of fog. Chaos erupted. Jenny scrambled to reconnect the ECG leads. The monitor blinked awake, showing a flatline, then a faint blip. One, then another. "Sinus rhythm returning," someone called out. A nurse wheeled the crash cart back, and I could barely keep my hands from trembling as we began oxygen support again. But the question wasn't how he came back. It was, had he ever truly left? Within 2 minutes, his heart rate had stabilized at a faint but steady 42 BPM. His blood pressure crawled back to 75/50. He wasn't speaking, but his eyes tracked us. Not randomly, but intelligently. He followed our movements, reacted to light, even blinked when we said his name. Neurologically speaking, Paul was there, barely, undeniably alive. We rushed him back into full critical support, EEG monitoring, intubation, and a stat CT of the brain. We expected massive anoxic injury. Instead, the scan revealed something else, a bizarre, low-voltage pattern across his cortical surface. Not dead, not normal. Dr. Simmons stared at the EEG, pale-faced. "It's like his brain went into a protective low-power state," he muttered. "Like hibernation. The term hibernation doesn't exist in human medicine. It's a myth, a poetic term for end-stage brain suppression." But Paul was rewriting those assumptions. His glucose metabolism, shown in the PT scan, was significantly reduced, yet consistent. His neurons weren't firing randomly. They were waiting. Over the next 6 hours, we kept him on close watch. Labs returned with strange inconsistencies. His electrolytes were in range, but his lactate had spiked. Cortisol was almost non-existent. His TSH was elevated, hinting at a sudden endocrine disruption. We called endocrinology, neurology, even a sleep researcher from Chicago who'd published on induced metabolic comas. No one had ever seen anything like this. Maria sat silently by his side, now holding his hand as though anchoring him to this reality. She refused to sleep, eat, or leave. She kept whispering the same words over and over. "I know you're still here, Paul." In the silence of the ICU, her voice became our only certainty. Around 3 a.m., Paul began twitching. Not seizures, more like purposeful, slow attempts to move. He squeezed Maria's hand, slightly, deliberately. When I came in at 3:15, he was looking straight at me. I tested his pupil response. Reactive. I said his name. He blinked twice. "That's yes, isn't it?" I asked gently. Another blink. My hands trembled again. We repeated MRI scans to rule out microstrokes or hemorrhage. Nothing. But the inflammation we had seen in the myocardium had now spread, subtly, into the brainstem. It wasn't an infection, and it wasn't autoimmune, but the pattern looked eerily similar to a syndrome we hadn't considered yet. I pulled Dr. Simmons aside. "Could this be something prionic?" I asked, half in fear. His face fell. The next morning, Paul stopped blinking. He didn't move, didn't react. The scans showed no further brain damage, but also no improvement. He was locked in, not just in body, but in some in-between space. His vitals held steady, but his mind retreated. For the next 48 hours, we were stuck in medical purgatory. A man who had died, come back, and now seemed to hover between both states. 48 hours passed and Paul didn't move. Not a flicker, not a twitch. His vitals were stable, but he remained suspended in that ghostly limbo, somewhere between a coma and something entirely new. I stood by his bed that morning, staring at the man who had defied death only to vanish inside himself again. We had no name for what we were witnessing. But I couldn't shake the feeling that Paul was still in there, watching. Dr. Simmons proposed a radical idea. Let's induce an fMRI command response, he said. We ask questions, tell him to imagine specific activities, like playing tennis, and observe if motor cortex lights up. It was a long shot, reserved for cases of locked-in syndrome. We didn't expect anything. But when we asked Paul to imagine walking through his workshop, his supplementary motor area lit up like a flare. The room went silent. Simmons leaned back, stunned. He's in there, he whispered, fully conscious. We had a man who had been declared dead. Now, not only was he alive, but he was mentally intact, aware, listening, and isolated in silence. We were no longer treating a medical condition. We were communicating with a soul trapped behind its own skin. That discovery changed everything. We restarted aggressive neurological therapy, began tactile stimulation and nonverbal communication training. Maria was overjoyed, breaking down in the hallway and calling her sons in tears. But the celebration was short-lived. Paul's EEG began showing irregular beta bursts, fast, sharp spikes that didn't match any known seizure patterns. We feared electrical storm activity, a rare phenomenon where the brain behaves like a circuit overloaded with unpredictable energy. Yet Paul's vitals remained steady. It was almost as if his mind was trying to push through, not seizing, but fighting. That night, Maria swore she saw his lips move. We dismissed it as hope. We were wrong. The next morning, while repositioning his body to prevent bed sores, Paul spoke. One word. Hoarse, dry, barely audible, but real. Stop! The nurse dropped the sheet. I ran into the room. Paul, say that again. His lips parted, but no sound followed. Still, his eyes opened. Not blank, not cloudy. They focused. Over the next 2 hours, he spoke 3 more words. Cold, Maria, and why. Each one was a whisper torn from the void. His oxygen saturation dipped with the effort, but his brainwaves remained organized. He was returning, not all at once, but piece by piece, word by word, like a diver resurfacing from a bottomless trench. With every hour, Paul became more responsive. He nodded, blinked twice for yes, once for no. He followed commands. But something still didn't add up. His labs now showed signs of rapid neuroregeneration, something we'd never documented in a case like this. His CRP remained low, but interleukin-6 levels began to spike, a marker usually associated with trauma-induced brain repair. His body wasn't just healing, it was adapting. One of the residents dug deep into older research and found a paper from 1998, a now-dismissed study that suggested the brain could enter a cerebral protective override during extreme shutdown. The theory had been discarded due to lack of replication. But Paul matched it, almost perfectly, as if his body had decided, unconsciously, to simulate death to survive a malfunction it couldn't explain. And then came the most chilling moment of all. I asked him, alone in the room, Paul, do you remember dying? He blinked twice. I asked again, did something happen after your heart stopped? He closed his eyes, a tear formed and slid down his cheek. He opened them again, and finally whispered, I wasn't alone. That sentence haunted the entire ward. I wasn't alone. It echoed in our heads like a riddle no one could answer. When Maria heard it, she collapsed into Paul's arms, sobbing uncontrollably. But to the rest of us, physicians trained to chart every beat, every breath, it brought something else, a profound discomfort, because it suggested that Paul had been aware during his death, and that he wasn't the only one there. The hospital's ethics board was notified. Paul's case had already gained traction among our academic peers, but now it was drawing attention from neurology departments across the country. We were operating in uncharted territory, reviving a man whose body had shut down completely and whose consciousness may have traversed something. It raised a terrifying question. What if death isn't binary? Paul continued improving, but erratically. Some days he would speak full sentences. Others, he would slip into an unresponsive state for hours. His EEG would slow, his reflexes dull. Then, just as suddenly, he'd return. It was as if his consciousness moved between frequencies, some accessible to us, others not. Dr. Simmons proposed initiating experimental neural modulation, a procedure never before tested on a patient with Paul's history. The treatment involved targeted transcranial magnetic stimulation, TMS, focusing on the dorsolateral prefrontal cortex and the pons, 2 areas believed to regulate executive awareness and subconscious arousal. We paired this with low-dose ketamine infusions, known for unlocking neural pathways and inducing plasticity. The risk was enormous, but Paul had already passed the threshold of death once. He looked at us and said, "Let's try." The first session was surreal. As the magnets hummed gently over his skull, Paul's eyes fluttered and he murmured strange fragments. White hallway. The door wouldn't close. Someone waiting. He trembled with each pulse, but never asked us to stop. During one session, he grabbed my wrist and whispered, "They don't want me to wake up." After the third treatment, something shifted. Paul's coordination improved. He began feeding himself, brushing his teeth. He laughed again. But the scans told a different story. His cerebral cortex showed signs of increasing electrical instability. Dr. Simmons warned us, we might be pushing too hard. But Paul insisted. "If I don't keep going," he said, "I might not come back again next time." On day 23, Paul suffered a seizure. Not a typical tonic-clonic. It was silent still, but unmistakably pathological. His brain spiked with synchronous bursts across both hemispheres, lasting 19 seconds. When it ended, he awoke screaming. "It's getting louder," he cried. I hear them now. Every time I blink. It wasn't pain that scared him. It was the voices. We adjusted the ketamine dose and added an anticonvulsant. It calmed the activity but dimmed his speech. Maria was torn. "He's coming back, but he's also slipping away again," she whispered to me one evening. The team debated halting the treatment altogether. Paul had become the center of a silent war between progress and preservation, between reaching further and respecting mystery. That night, Maria brought in something unexpected, a small hand-carved wooden box. Inside was a photo of their wedding, a dried flower from their first date, and a note she'd written decades ago. "Come back to me, no matter where you go." She placed the box on his chest, kissed his forehead, and said, "No more machines, no more pulses. Let's just be here." Paul looked at her with eyes wide and clear. "Okay," he said, and just like that we stopped. No more TMS, no more drugs, just rest. For the first time in nearly a month, Paul slept naturally. No machines, no codes, only silence. Not the kind that terrifies, but the kind that heals. Paul slept for 16 hours straight. No interruptions, no neurological events, no fear. When he woke, the change was visible. Not dramatic, not some miraculous movie recovery, but subtle, deep. His gaze was calm, rooted. He looked at Maria and whispered, "I dreamed of silence, but it didn't feel empty." For the first time, he didn't flinch when the nurses entered. He didn't ask about the voices. He simply asked for coffee. Over the following days, his brainwaves stabilized. The chaotic bursts vanished. His EEG returned to near baseline. No further seizures. His verbal responses grew fluid. Physical therapy began, and though his muscles had atrophied from weeks in bed, his will didn't. On the first day, he stood with help. On the third, he took 4 steps. By the end of the second week, he was walking short distances on his own. One afternoon, I sat beside him and asked, "What do you remember between death and now?" He smiled faintly. "Not much, and then too much," he said. "There was a place, white, endless, but it wasn't the light people talk about. It felt like a waiting room, and I wasn't alone. There were others, but I couldn't see them, only feel them." He paused. "They were sad, or maybe unfinished." Maria sat next to him, squeezing his hand. "Maybe they're still waiting," she said gently. Paul nodded, tears welling. "But you pulled me out," he whispered. "Your voice. I followed it. Every time you said my name, I felt it, like a thread pulling me upward." The medical staff documented everything meticulously. We presented the case at a national conference. Some called it spontaneous return of circulation, a rare post-mortem reflex. Others called it Lazarus syndrome. But no one could explain the brain activity, the responsiveness, or the memories. It became a case study. But to Maria, and to us who were there, it was never about data. It was about Paul. He stayed in rehab for 3 weeks. His fine motor skills improved daily. He began writing again in a journal, documenting his dreams, his thoughts, his return. He described flashes of light, snippets of voices, the sensation of watching himself from the ceiling. Not like floating, he clarified. More like being stretched, like I existed in 2 places at once. On his final day at the hospital, the staff lined the hallway. He walked slowly, cane in hand, Maria beside him, smiling through tears. He paused at the nurse's station and said something none of us would forget. "Thank you for not giving up, even when the machines did." He returned home to a quiet life. No media appearances, no sensational headlines, just days filled with fresh air, music, carpentry, and healing. But something about him had changed. He spoke more slowly, with intention. He hugged longer. He listened deeply. And every year on the day of his death, he sat in silence for exactly 7 minutes. Eyes closed, hands folded, as if paying respect to a place only he truly knew. For us, the doctors, nurses, and techs who lived that month on the edge of belief, Paul became more than a patient. He was a mirror, a reminder that science explains much but not all, that the human body is a mystery and the human spirit even more so. He gave us a reason to believe in what we couldn't measure: hope, love, and the possibility of return. And as for Paul, he lives, quietly, gratefully. He still builds furniture, still makes Maria laugh, still leaves room in his life for silence. Sometimes, he told me during a follow-up visit, I think we all carry a door inside us. Mine opened for a moment, but I chose to close it and stay. Paul Whitaker's journey reminded us that medicine is as much about mystery as it is about method. We rely on machines to tell us when life ends, to track heartbeats, record brainwaves, define thresholds. But Paul taught us something science often forgets. There is no monitor for will, no sensor for the soul's endurance. Sometimes, the deepest fight for life happens in silence, behind closed eyelids, beyond what we can measure. His case changed the way we speak to patients in comas. We talk more now, we whisper their names, we believe more fervently that someone might be listening, even when all signs say otherwise. Paul didn't just survive. He returned with a presence that made every one of us question what we thought we knew about death, and what might exist on the other side of it. His recovery wasn't just physical, it was spiritual, emotional, and quietly revolutionary. And maybe that's the lesson, that in the space between breath and silence, there's room for the extraordinary. Thank you for joining us on this unforgettable story. Make sure to subscribe, give us a like, and comment below with your thoughts, and let us know what story you'd like to hear next.